the Committee on Healthy Women, Families, and Communities. I strongly believe it is our duty to, pardon me one second. Can we close this door? I strongly believe it is our duty to engage and educate our community around issues of public health. This briefing today will provide some much needed insight on public health trends in our city. Will hopefully allow for a better understanding of the social and economic determinants that shape the health of our communities and the residents of our city. First, I want to say thank you to Chief Martinez and Director Lupi for coming today to brief the council. And I know we have one more person. What is your last name? Dooley, Dan Dooley. I knew Dan, that's okay. And Dan Dooley for joining us as well. And Marta for her support. And also my Director of Research, Lanice Wallace, for all of her efforts to make this briefing possible. And Carrie Jordan and our media team for ensuring that this briefing, not a formal hearing, but this briefing could be live streamed for the public today. And we've been soliciting questions and things, and so appreciate the opportunity, even if folks can't be here physically, to have that interactive dialogue. So I thank you all for being here to brief the council and the public on the Health of Boston report, which was released in February. I commend the Health Commission for producing this report annually and for being here today so we can understand the implications of these determinants on citywide health outcomes, from fatal overdoses due to substance use disorders to the trauma of rampant community violence. It seems our ability to create a healthcare system that works for all of us and not just a select few is an ongoing challenge. Nonetheless, we are making real and good progress. Insurance coverage in Boston and across the state is near universal, making access to healthcare services much more attainable to all of our residents. Despite these achievements that are highlighted within the report, many inequities remain across many racial and socioeconomic groups. I look forward to engaging in conversations like these more throughout the year and to partnering with you to work to eliminate the inequities and barriers that impact our ability to achieve optimal health status for all, regardless of race or zip code. This report gives us an important foundation to tailoring our work in public health to address the most urgent issues of our city and to continue our efforts to address the needs of Boston residents, especially the most vulnerable amongst us. Thank you. And so if you would like to extrapolate and highlight whatever you'd like from this comprehensive report. If you would also share with the public, if they are interested in physically accessing this report, how that might be possible online or if they could get physical access to one. And then just before you speak in your presentation, if you'll just provide your name and your title for the public. Thank you.
Great. Thank you, Councilor. Thank you for having us, Chief Marty Martinez, Health and Human Services Chief for the city. Just thank you so much to the councilors who are here and for everyone that's joining us to sort of learn more about the Health of Boston and the report that you're going to hear. Commissioner Valdez-Lupi and Dan Dooley, who's our Director of Research, the Research and Evaluation Office, are going to sort of walk us through some of the highlights and the overview of what the report has shown and sort of look at some of the data that's there. I think one of the things that's important to remember is that in order to do is take your words, to create optimal health for all Bostonians, regardless of what zip code you live in, we have to understand what the data says. We have to understand what the numbers say, not just our instincts, but what data tells us not only about our progress, because I think you'll see in this report there's been some great progress in different areas, some gains we've made and some headway we've made on building a healthier community, but also to own the disparities that continue to exist and what those persistent challenges are to close those disparities and to better understand them. Yes. So that's kind of what we're going to cover. We're going to see some of the highlights and we're going to recognize some of the challenges. And I think only when we face those and raise them up are we really able to move the needle.
Yes. And Chief, yep. I did just want to, I was remiss to acknowledge, and so for all of the progress that has been made and the progress to come, that certainly does require a collaboration and not just partners within City Hall, but certainly in community. And so I do want to acknowledge ABCD and Irvine Goldson for her advocacy and what she does on the front lines every day. We thank you for your partnership. Okay.
Absolutely. Thank you. So now I'm going to turn it over to Commissioner Valdez-Lupi to sort of get us started.
Thank you, Chief, and good afternoon, Councilor. Thank you for hosting us this afternoon, and Councilor Flynn. My name is Monica Valdez-Lupi, and I'm the Executive Director of the Boston Public Health Commission, the local health department for the City of Boston. Dan and I will, as Chief said, walk through the report for you, but I also want to acknowledge our staff from our Research and Evaluation Office who are sitting in the audience. One thing that I would want to emphasize is that this report that we do biennially really remains cutting edge in terms of the information that we're able to provide and serves as a best practice and a report and a framework that many of my colleagues around the country follow. So I want to acknowledge the staff and Dan for all of their hard work throughout the year to do the analysis. And so with that, we'll jump in. So what's in the health of Boston? And on this slide, you'll see the table of contents from the report. I won't read through it other than to say that in addition to important health data that we have gathered and analyzed, there are also some chapters that really focus and really zero in on the persistent health inequities that we're seeing, trends in those, and then also the social determinants of health. So the report really does a nice job of weaving in what are those root causes that contribute to the persistent health inequities that we see in certain racial and ethnic groups. There are 15 chapters because of an effort to redesign the report, which I hope will, since you have hosted this gathering in previous years, hope that you can appreciate some of the changes that were made, but it's doubled, I think, in size because we've used an in-house graphic designer, have tried to be really conscious of using plain English when describing the data and the analysis that follows, and then also use of not only tables and bar graphs, but really the use of infographics to display the information that we're seeing and looking at. In this next slide,
very nice.
oh, thanks.
Yes.
In this next slide, where do we get the data that forms the basis? And some of the data, such as the adult health and risk factors, is actually data that we have in-house, and the staff do the analyses in-house. But we also rely on data from our partners at the Boston Public Schools, so the Youth Risk Behavioral Survey, our colleagues at the state Health Department in terms of birth and death certificate data, and also national data sets. But you can see in this slide that there are numerous different data sources that the staff rely upon in order to do the estimates that are included in the report. So there are two, if I were to summarize the two primary reasons that remain important for the Public Health Commission to develop the report, it would be twofold. And first, it's really, as you said, and you set it up very well in terms of assessing the health of our residents and really providing a very comprehensive, detailed view of what the health of Bostonians looks like across our different neighborhoods, to lift up where we see trends, not only focused on the deficiencies in terms of health inequities, but where we see improvements. And Dan will be able to highlight the improvements that we've seen over time when he digs a little bit deeper in terms of that data, because it doesn't happen in terms of some of the data that you'll hear more about in terms of infant mortality, for example. The improvements that we see didn't happen in the 2 years or the 5 years that we are able to look at that data. That is actually improvements based on investments by the city and the state in the commission to really address some of the deficiencies and health inequities that we've seen. So really, first is to provide an assessment of the health of our residents. The second is to take that information and promote it, to share the information with different constituencies, policymakers, elected officials like yourselves, to use the data to help drive program and policy design, and to ensure that, as you said, that we're investing our resources appropriately in the right neighborhoods to tackle the right issues. So there are a number of different constituencies that rely on the health of Boston, and on this slide, just a sample. Clearly our healthcare providers, our community health centers, and our teaching hospitals in the city lean on the data and the analysis that we provide through Health of Boston as they're developing their different community health needs assessment reports that are required by the state and the federal funders that they are accountable to. Again, I already mentioned the policymakers, but also community coalitions. So we work with a lot of nonprofit groups to push out this information and at times to do specialized analysis for community-based groups. We also partner heavily with our academic institutions in the city and share this information with them as well throughout the year, not just when we release the report. I've already acknowledged our research and evaluation team, but in this slide we show that in 2017, they fielded over 60 data requests that required analysis on the staff's part. A little less than half, really, of those requests are from our internal partners, so across our over 40 programs at the Commission, but over half are really external partners who reach out to Dan and our colleagues at the Research and Evaluation Office to run different analyses. And so those external partners I've already mentioned include individuals, other city agencies. In fact, a third of our external requests came from our sister partners, other agencies who actually work with public health in terms of really looking creatively across the administration at different policies and interventions that can be developed to address health inequities. So those partners include the Boston Planning and Development Association, Boston Housing Authority, and Boston Public Schools. 27% of our requests actually came from the community health centers, hospitals, and healthcare-related nonprofit agencies. And then about a quarter came from universities and students who might be working on different capstone projects or different research initiatives. So, there really is a range of different constituents who tap into and use the health of Boston. I'm actually now going to shift over to Dan, who's going to walk us through some of the data and how to access it, and that's the segue. So you asked how can individuals get the report. So Dan's going to walk through it.
Thank you. I'm Dan Dooley, Research Director at the Commission. The slide you're looking at here shows we've got the report located on the web at two different locations. So one at the Boston Public Health Commission, where you can actually access individual chapters as well as appendices that give all the rate data behind the charts that are in the report itself. It's also, the full report is also you can reach at boston.gov. And then we wanted to mention that we're actually in the process of developing an online data visualization tool that will allow for interactive access to the data itself. This will be more in line with data dashboards that you may have accessed already, and it'll allow for different types of stratifications to look at the data that way and cut it different ways. That should be available sometime this summer. I also wanted to mention that the report itself is about 660 plus pages of information, which is extensive, and it would take me days to get through it all. So this is basically highlights and just a brief summary of some of what's in there, but it's also meant to give you an idea of how to access the data and what you'd be seeing. Also, when we talk about changes in these data, it's very rare that two data points are the same, and so when we talk about rates being higher or lower or changing over time, that's the result of statistical tests that we bring to bear to measure that, so that we're rather sure or confident that what we're seeing as change isn't just the result of randomness or other factors. As Monica mentioned, we've made a number of improvements to the report, and this is an example of some of the infographics that we're presenting. These are presented to help folks visualize then the data itself and interpret the data. In this case, we can see, in top left, 1 in 3 adults having tooth decay or gum disease in 2015 data. Another example of improvements in this year's report are arrow summary tables that we've generated for quick summary comparisons. In this example here, we've got health indicators going down the left side, And then the arrows underneath the various racial ethnic groups that we present, and then the sexes indicate whether or not those rates have increased or decreased or have stayed approximately similar when compared to the reference group. Our racial ethnic groups comparisons throughout the report are comparing to the white residents of Boston, and our sex comparisons throughout the report compared to the male residents, female to male. We also have these types of summary tables that will give same type of table that will show the arrows up and down if rates are increasing or decreasing over time. Then another inclusion in this year's report is inclusion of unique perspectives. At the conclusion of each chapter, we have unique perspectives from community residents and from public health professionals, where they're giving a perspective on essentially the content of the chapter itself. So making, I think it helps to personalize some of the data and the experience that's being, that Boston is experiencing. So at this point, I'm going to move now and start to discuss some of the progress and some of the improvements that we've seen. I'm also in the process going to try to mention some of what the Public Health Commission has done in hopefully contributing to the progress that we're seeing. I'm not able to mention everything. There's many many different programs, but I'm going to point out at least a few as we go along. This first slide actually depicts improvement in the infant mortality rate for Black residents and Black infants in the city of Boston. Let's see. From 2006 to 2015, there's been a 36% decrease in the infant mortality rate. That said, by 2015, we still have infant mortality rates for Black infants and for Latino infants are still higher than for white infants in 2015. We believe that the 36% decrease is somewhat attributable, at least to Boston Healthy Start Initiative program and Healthy Baby, Healthy Child programs, and the work that they're doing to bring down infant mortality. This slide here shows improvement in lowering the teen birth rate among female residents ages 15 to 17 by race ethnicity.
Excuse me, Dan, can I ask a question? And then we don't have too much of a back and forth because that will protract
fine.
this. But I was just curious, and I don't know if this was going to be part of the presentation, but on infant mortality specifically, and you cited some programs that we're certainly very grateful for. So is the cause for infant mortality related to prenatal care and access to nutrition and the decrease of other social determinant stressors like poverty, racism, that sort of thing? Is that what we would credit as the contributor to Black infant mortality?
Well, there are many, many contributors, but those all are
Okay.
playing a part.
Okay.
There's many risk factors for infant mortality. Perhaps chief among them is low birth weight births, and the factors that you're discussing and describing actually contribute to low birth weight births. So, and we'll talk a little bit further in the presentation around the role of the social determinants, but those are more the upstream contributors than to the factors that actually lead to the poor health outcomes. And certainly then our programs, Healthy Baby, Healthy Child, and the Healthy Start Initiative are invested in trying to improve those rates, access to prenatal care, lowering low birth weight, and then, access to nutritious foods and lowering stressors, et cetera.
Thank you.
Well, so this, just to wrap up on this is the female reduction in the female birth rate among females ages 15 to 17, which has happened over from 2011 to 2015. We've seen reductions among Latinas and among Black infant and mothers. And those reductions have been then part of the overall reduction for Boston. This is part of our CAF Bureau has a health resource center where they they provide sexual health education in schools that contribute then to bringing down the rates of pregnancies among teenagers. Let's see. This next slide shows reductions in elevated blood lead levels by year. These blood lead levels have been coming down among children. These are for children under age 6 that are tested for blood lead. We recognize and know that blood lead levels, elevated blood lead levels, create trouble with learning, cognitive disorders, and could create brain damage eventually. So there's been a lot of effort and regulation laws to bring down blood lead levels. And we have, in the commission, we have a very effective lead paint poisoning prevention program, that childhood lead poisoning prevention program that has worked with homeowners and contractors to reduce lead paint, which is a primary exposure for elevated lead levels. It's paint chips that get consumed. We also are we work quite a bit in the high-risk areas to bring down those. So we're down to about, for males and females, around 2% in 2015 with elevated blood lead levels.
And I'm just curious, in order for you to have this accounting, children have to actually get tested. And so what is the prompt for that?
Now, I'm not, I don't know offhand. Do you know?
Okay, that's
I
okay.
believe when you're going in for your pediatric appointments, that's standard screening that's done, but we can confirm.
Well, I guess my point is, since we know what contributes to disparities is that even with having insurance, culturally, many families still don't prioritize preventative health. Mm-hmm. And so unless there is a crisis or some really obvious, maybe a child is coughing or wheezing or seems fatigued or delayed, they might not be prompted. So I'm simply just saying that, I trust the data, but there's probably many children that have suffered or been exposed and who simply haven't been tested. So we couldn't account for them in these improved outcomes.
Right. So we can find out for sure. My recollection is that it's more routine,
Okay.
as Monica was suggesting, than someone coming in and requesting a test or something like that. It is.
And
Okay.
I think as a city, we've done a tremendous job in terms of the housing stock to work with landlords and industry around lead paint. And so I know our home visitors and our environmental health program, that's where this work falls under, as Dan said, in terms of lead poisoning prevention team. But we can confirm with you the process.
Great. Thank you.
You're welcome. The next slide here shows then success we've had in reducing youth cigarette smoking over time and in reducing youth binge drinking over time. Binge drinking could qualifies as 5 drinks for males, 4 drinks for females in one sitting. Those would be alcoholic drinks. You can see that the rates have decreased for both, and in 2015 data, Boston had a rate of 5% for cigarette smoking among high school students, public high school students, compared to 9% in the U.S. And youth binge drinking, Boston has 11% of students reported binge drinking compared to 18% in the U.S. And on the smoking, I think we're just now getting the 2017 data, and it looks as though cigarette smoking is continuing to decrease among high school students. just back on that, I do want to mention that we believe that some of the reduction in the smoking is related to tobacco control efforts, that our tobacco control program has worked to help raise the age to be able to purchase cigarettes from 18 to 21. And then have also been involved in limiting the access to flavored tobacco products by requiring that they're only available through adult-only tobacco retail stores. This next slide presents reductions in asthma hospitalizations and heart disease hospitalizations for Boston. The reductions have happened, let's see, I'm just decreases. The reductions have happened across race and ethnic groups for asthma hospitalizations, but rates remain higher for Black and Latino residents even after the decreases. Similarly, decreases have occurred across the Black, Latino, and white racial ethnic groups for heart disease hospitalizations and for Boston overall. Asian residents have lower heart disease hospitalization rates than do white residents in the city of Boston, 2015. Well, let's see, this says 16. I wanted to mention that in terms of asthma reductions, we do, again, the Public Health Commission has an asthma prevention and control program. It's been very active in conducting home visits. These home visits, community health workers work to reduce the asthma triggers that cause hospitalizations, lead to asthma exacerbations. Also, with the heart disease hospitalizations, we're very active in working to provide access to healthy foods, to reduce consumption of unhealthy foods as well. Okay, now, is that cancer? Mm-hmm. Okay, I need my glasses, okay. So we've also experienced decreases in cancer mortality from 2011 to 2015. Reduction in cancer mortality overall. In 2015, then the rate, cancer mortality rate for Boston was equivalent to what we see for Healthy People targets, Healthy People 2020. And a little bit higher than what we see overall in the U.S. and in Massachusetts. The cancer mortality rate in Boston has decreased 12%. That includes a reduction among Black residents of 18% reduction. The rates for Latino and Asian residents are lower than the rate for white residents. I want to take this moment to mention, too, we're also about to release a cancer report that looks more closely at cancer incidence and mortality overall and among 5 cancer sites. This report will cover 1999 to 2013. The data are a little more dated, but it's a good presentation to be able to assess the relationship of incidence to mortality even over that time period. That should be coming out within the next month.
Excuse me, I'm sorry, Dan. So would that sort of be in the aggregate different kinds of cancer? And
yes,
okay.
So it's cancer overall plus 5 cancer sites. We've got lung cancer, female breast cancer, liver cancer, prostate cancer, and boy, it's just escaping me right now.
That's fine.
Colorectal.
Okay,
Thank you. Okay. So at BPHC, we've been very involved in the cancer prevention, with our cancer prevention program. In 2014, we did actually collaborate with folks over at Dana-Farber, form the Breast Cancer Equity Coalition that is addressing then disparities seen in higher rates of breast cancer mortality among Black women in the city of Boston. So those are some of the successes that we've experienced so far that we see in the data. Now I'm going to switch focus to discuss something more about what are considered new and continued challenges within the data. As we mentioned earlier about low birth weight, that low birth weight is a risk factor for infant mortality. And though we've seen reductions over a longer term in infant mortality, in the last 5 data years, we do not see reduction in the rate of low birth weight births. Additionally, what we see are higher rates for Black and Latino births than we do for the white low weight births, 2015. This next slide shows hypertension. Oh, wait, is that? Here we go. This is hypertension among adults by year. This has not changed. It has basically stayed steady, even though we've been bringing down the rate of heart disease over time. The hypertension rates have not decreased. The Healthy People 2020 goal is around 27%. Boston's achieved that goal at close to 25%. But Boston's achieved that goal because the white residents, about 20%, report hypertension, and we have higher rates among Latino and Black residents in the city of Boston. The rate for Asian isn't here. We need 2 years, data years for Asians, but it's similar to the rate for white residents. The next slide presents obesity among adults by year. This rate has not changed over time, basically. It's remained steady over time. And we see a similar picture where we have Boston at 22% overall, is lower than the Healthy People 2020 target of 30.5%. But what we see is that that we have a lower rate of obesity among white residents, higher rates of obesity among Latino residents and Black residents. We actually have because of the data year that's presented here, again, the Asian rate is lower than the white rate of 17%. And this next slide then presents diabetes among adults. And the rate, our rate of diabetes, as is happening at many places around the country, has increased over time. We are still at this point, our overall rate is 8%, which is below the U.S. rate of 9.3%. Diabetes rates for Black and Latino residents are higher than for white residents in the city of Boston. The rate for Asians is equivalent to the rate for white residents.
Can I just ask something real quick? Sorry. So, Councilor, one of the things I think to add that's important is that, we see these benchmarks to the, to the national standards, and although in many of these scenarios, we're better than that national average, but what's difficult to sort of make sure that I want to make sure our viewers understand, and I know you understand already, is that this inequity that exists between the health and well-being of our white residents and those of our Black and Latino residents particularly sometimes can be a little bit confusing because the citywide average will still be better than the national average or the national rate. And so I think it's important for us, and this is why these are all challenges, even though if you benchmark it, it looks like we're doing better than the country. We have to continue to think about where that gap is and that inequity, and how are we focusing on the disparity. Some of the programs do great work, but clearly the disparity still exists in a lot of these indicators that we're reviewing. So for me, I just want us to recognize that as it still presents more work to be done.
Absolutely, and the public I'm not sure if they can see these graphics. I mean, just to, for the purposes of the record, so that people understand how stark the contrasts are in hypertension, obesity, and diabetes. So for Black residents, 36% hypertension, Latino 27%, white residents 20% for hypertension. Obesity, Black residents 32%, Latino residents 30%, white residents 17%. And then for diabetes, Black residents 15%, Latino residents 11%, and white residents 5%. And as you were saying, and I'm not sure what the plan is ultimately around our Asian data, because you were saying you need 2 years. So is that about us needing to be more deliberate in the surveying? It's my recollection from the last report that the Asian American community actually has the highest life expectancy in the city of Boston. I think their average was like 80, but they were disproportionately bearing things, lung cancer, more smoking of cigarettes, and that's my recollection. But so what would need to happen for us to be able to get a full composite, including the Asian community?
I believe we've actually addressed that in the new data that we're getting 2017.
Okay.
We've actually changed the sampling structure so that we oversampled in areas to boost the Asian sample size. That will then permit us to put that statistic out, and that was largely the result of recognizing this, limitation that we were experiencing on occasion. That said, the survey itself, there are limitations in that. It's done by telephone. It's done in English and Spanish, and so. And then I've spoke with a number of folks in the Asian community who've shared with me that culturally, there's challenges to getting that kind of information, certainly over the phone.
Not everyone feels comfortable or safe. It's sort of very prying, it's private information.
Yes.
Yeah, so some cultural barriers.
Right.
Definitely.
I would also
yes.
add the challenges in getting a large enough sample size on the Asian. What happens is there is data at the state and national level to show that when we display data this way, it makes it seem as if there are no health inequities or disparities in the Asian population, when in fact, when you look at certain chronic diseases like diabetes or cervical cancer, and are able to stratify by particular Asian ethnic groups, that those rates actually are more comparable to their Black and Latino
Sure.
counterparts. So
No, absolutely, and we find that in our schools when it comes to academic outcomes and the achievement gap as well. Because we're not seeing Asian data, in the aggregate, including Laotian, Cambodian, Filipino, right? And so it can hide those disparities. And I was going to ask that question. That was a very good segue, because I'm not sure within that surveying for Black residents, knowing we have a huge Black immigrant community and a Black Latino community. So, I'd be curious to better understand if we're seeing a contrast or a disparity for Black immigrants versus African Americans, or if those are consistent, and the same for all of the other groups as well. But appreciate this floor to better understand where we are.
And Dan could probably speak to this. I can't recall if it's in the Health of Boston, but there's also evidence that shows that immigration status, particularly if you're a recent immigrant, often has a protective factor initially, and then over time, health conditions worsen because some of those social determinants in terms of racism, poverty, economic opportunities. So, I think you're spot on in terms of the nuances and limitations that we have with some of the data.
Yeah, and I can share that is, in fact, at least years in the U.S. Is in the data itself. We don't have it further stratified by race or ethnicity, but we could investigate that to see if we could look, how many years we could put together to try to find out, if that's possible with the data that we've received. But we do know, as Monica said, that oftentimes it's the case that years here, especially among non-white group population, the years here are something of a protective force for health outcomes.
And then my last question is, how many of these disparities, social determinants aside, is some of this genetically passed on? So, and so the disparities just persist and perpetuate without personal disruption and intervention. If your family has historically had people that have diabetes or hypertension or are obese, what are the odds that you're predisposed? So I'm wondering, how many of these disparities are generational and are about literally DNA, and that's exacerbated by social determinants? Is that something you could speak to, or do you think there's much merit to that?
I can speak to that. It's a great question, and I think there's a lot of research trying to pull that apart and try to understand the relative contributions to the disparities that we're seeing. It's a very difficult area to try to understand what portion is presenting, was a contributor to the outcome. And so that's the type of information that would result from very well-designed and robust research.
Mm-hmm. Well, let us know the financial investment that you need to do that, because the health of our communities and the city determines everything. We don't just only care from a place of benevolence and general care and concern, but it is about our workforce and our economy and the productivity of the city. So, from my vantage point, it is the best investment that will yield the greatest ROI. So,
Great. Thank you.
okay.
I'll move on. This is a presentation of pretty much the three indicators that we just saw. But now it's diabetes among adults, hypertension among adults, and obesity among adults. But this is an example of our maps, our neighborhood maps. And what we find basically, the way we present these data are the darker colors represent the higher rates, and the lighter colors represent the lower rates of these chronic disease. In particular, when the higher rates are when you compare to the rest of Boston. So in this case, all three maps are showing the same, basically the same group of neighborhoods with the higher rates that run along what we describe sometimes as a crescent shape. We've got largely it's Roxbury, our two Dorchester regions, and Mattapan with higher rates. And then at times we'll see parts of the South End included there as well. I'm going to now turn in, the next few slides are going to discuss a little bit about what we have in our substance misuse mortality data. This slide here shows that we've had increases in overall substance misuse mortality from 2011 and 2015, a 54% increase. We also have a 49% increase in alcohol-related mortality and a 71% increase in drug-related mortality. So it's the alcohol and the drug that are combined for the overall. So we're seeing increasing rates across the board. But the next slide looks at these same three indicators, and we're excluding one of the opioids, fentanyl, from the calculation. And when we pull fentanyl out, what we find, even with all the other opioids involved, when a case that involved fentanyl pulled out, we see that we have not had an increase, statistically significant increase, in the substance misuse mortality from 2011 to 2015. So fentanyl is recognized as being a huge contributor in part of the opioid epidemic in terms of the mortality component. Certainly the epidemic itself extends, it's much larger just than the mortality component, but fentanyl is a driver in Boston, at least, around the increase in mortality. This next slide, then, with fentanyl back in the mix, this next slide looks at the increases in substance misuse mortality then by race, ethnicity. For Black, Latino, and white, we've got significant increases. We didn't have enough cases among Asian residents to rate their experience over those years. So the take home here is that the increases, and this is likely influenced by fentanyl as well, so in effect the fentanyl component has likely contributed to increases we see among Black, Latino, and white residents over time. And this next slide then presents leading causes of premature mortality by year. And premature mortality is mortality among residents under age 65. This by year presents a ranking of the leading causes of mortality. And for residents under 65, cancer is the leading cause of mortality across the board, ranked number 1. Ranked number 2 for the first 3 years, 2011 through 2013, is heart disease mortality. But that was then moved to the third in 14 and 15 and was replaced by accidents. Now, accidents in this largely reflect the increase in accident mortality, accident-related mortality. It's definitionally is another exposure of the influence of the unintentional overdose, opioid overdose. Let me just check line 27. We calculate that 71% of accidents were unintentional opioid overdose, and if we were to rank that explicitly, it would rank third among premature mortality by year. So if you just isolate opioid overdose mortality, it would rank third. 2015. And this next slide presents leading causes of injury mortality by race ethnicity. And so this is all ages. And what we see here are differences in ranking, whereas for Asian residents, the leading cause of injury mortality is falls. And injury mortality is considered preventable. So falls for Asian, but leading among Black residents is homicide, and then among Latino and white residents, unintentional poisoning. Again, the influence of the opioid overdose there. Ranking number 2 for Black residents is unintentional poisoning as well.
Just before you go into the social determinants piece, I know we're short on time, but Councilor, I think if you think also about the, a little bit around the mortality rates around substance use and substance disorder, you know, this data gets us to 2015. Clearly, the experience on the ground by our providers and our CBOs is that it's continuing to be much higher, and that we continue to see that. And also, one difference here, you see the differences in race and ethnicity. There's statewide data for our viewers also that sort of looks at the Latino rate dramatically increasing, the overdose rate amongst Latinos. We don't necessarily yet have that specificity for the current years or the closer years we're at, but thinking about the face of the opioid disorder and what it looks like, I think is also part of thinking about how do we make sure all communities are reached within programming and services. So I just wanted to point that out.
No, I appreciate the point, because there's sort of a, not sort of, there is a one-dimensional narrative. And you know, substance abuse disorder addiction is not an illness that discriminates. Even if there are some populations that are disproportionately impacted. I also worry that with such a focus on the crisis of the opioid epidemic and overdoses, that we are not focused on other substance abuse disorders, because I do see on the ground an increase in meth use and sort of so much attention and programming and advocacy directed there when we still, in general, have a substance abuse disorder and addiction problem that, opioids don't have the monopoly on. So, but
Absolutely.
bigger conversation.
Yep.
This next slide then presents our framework for social determinants of health. And social determinants could be thought of as the conditions in which people live, work, play, or go to school. They're basically, these are upstream factors that contribute to poor health or contribute to health outcomes. Could be poor or not so. Our framework then recognizes in social determinants, we're talking about social capital, education, transportation, employment, food access, social economic status, housing. And then we, in our framework, also acknowledge the role of racism and all forms of racism that play a role in the relationship with social determinants of health. So we consider racism to be a social determinant itself, but then also a factor that contributes to other social determinants that we have identified. So again, these social determinants are the upstream factors that contribute additionally to health outcomes, in addition to, as we were talking earlier, genetics and health behaviors. This slide here presents one of a number of tables that we have where we actually present a social determinant. In this case, it's housing status. And we look then across indicators to see what is going on. For housing status here, we're able to look at those living in Boston Housing Authority or BHA. We're looking at renters who receive rental assistance and renters who don't receive rental assistance. And then we're comparing them to our reference group, homeowners. And what we see across the board here for asthma, diabetes, hypertension, obesity, persistent anxiety, persistent sadness, that those living in the Boston Housing Authority and renters receiving rental assistance such as Section 8 have higher rates of all those indicators when compared to homeowners in the city of Boston. And depending upon it, it's often the case that those rates are in fact higher than renters not receiving assistance. We have the similar types of tables for for employment, I believe, education, so we're able to better understand then the relationship of these determinants and to the health outcomes being measured. So one of the ways we have recognized that we address social determinants is by acknowledging and enhancing our community assets. This slide here lists what we believe are some of the community assets that exist, and by community assets we're speaking about engaged communities and partners, community-based organizations, community health centers and hospitals, engaged state and city agencies. But we're also talking about physical and built environment assets and economic assets, as well as strong leadership. I thought one way to sort of illustrate a relationship between the outcomes that we see and some of the determinants would be to consider a map here. This map shows, I believe, higher rates of, I can't see exactly which one, but I believe that's the emergency department visits, and it shows the crescent shape, the neighborhoods within the crescent shape there. Roxbury, our two Dorchester regions, Mattapan, with higher rates of emergency department visits for assaults.
Excuse me, could you tell me how you are defining assault
The assault,
for the purposes of this research?
Yeah, so these are emergency department visits, and the case definition is based on ICD-9 diagnoses. And so when a patient is seen, they get diagnosed, and then the determination is made whether or not their injury resulted from someone else intentionally, and that would be
Okay.
an assault.
So that's broad. So that could be domestic, it could be sexual, it could be firearm, it could be knife, it could be, it's very broad.
very broad.
Okay.
But it's where the intent where someone harms somebody else.
Okay, thank you.
You're welcome. So we consider then this next map, and I believe when I flip the order, this, I can't see exactly which one. Oh, this next map shows voter turnout rates. And here, this would be a measure of community access. And we actually have, largely through the same area, the lower voter turnout rates for general elections in the city of Boston. So that would imply that the residents are less engaged in the voting process. Additionally, then, this slide is the last slide. This shows the percentage of general open space by neighborhood, and we recognize open spaces as being an asset to communities necessary for relaxation and physical exercise. One more, and this map shows then the food resources by neighborhood. In this map, we've got we've noted where there's food pantries and meal programs, largely community gardens, farmer markets, and grocery stores. So we've already acknowledged to folks,
I'm
but
sorry,
it's
on
been a
that
big team.
question,
Yeah, go ahead.
on that point, so one of the things I wonder we can, tackle to improve health outcomes and to prevent disparities, and we know food deserts are a real issue, and so I appreciate your highlighting this as a social determinant, but it could be misleading because if there is a community that you, sort of put a pin in your visual map. So I live in Dorchester, I live in Ashmont, and across the street from me is a place where I could buy some grocery items, but it is a liquor store. And it is what is in the closest proximity for myself and many of my neighbors. But everything sold there is processed, high corn fructose, refined sugars, all those things. There's a 7-Eleven a little bit further up that is trying to offer a greater, diversity in offerings. But again, for the most part, what you're going to buy in there is something prepackaged, lots of preservatives and, artificial. And so I wonder if data like this accounts for that. So, you could cite a community as having access. Maybe there are many bodegas or, things like that. And most of our bodegas do actually offer fresh produce and things like that. But I just wonder if that's something that could be accounted for, or something to be, mindful of. Even our food pantries and what is the quality of food that is being provided there, or our senior meal sites, are the offerings things that are improving outcomes or contributing to these disparities? So the food is accessible, but is it quality?
And I think that's a great point. The data, as we receive, doesn't allow us to make that type of differentiation. We are able, we do include when we have access to the data. In this case, let's say the farmers market, where it's much more reasonable to conclude that you're going to get access in farmers markets to vegetables, fruits, to healthy foods, but we're we basically have limitations in the data that we can access.
So I would say, good question in terms of food deserts. On the flip side, there are food swamps. And so we might not have that available in the Health of Boston report, but in terms of that piece, it could be something, I suspect it's something that at the program level, so on our chronic disease team, they had a multi-year grant that they received from the CDC. We branded it Let's Get Healthy Boston, and I do think some of the neighborhood champions and community groups that received these grants actually looked at that very issue in terms of what are the offerings that are
Like
available.
a Common Square Neighborhood Council,
Sure.
folks like that, maybe
Yes.
TNT.
And I also would suggest that the Office of Food Access, less holistically, but has a variety of different efforts through the city that's trying to partner with farmers markets, pantries, trying to think about what food is available at community health centers, which exist in all of our neighborhoods, right? So I do think there's some of that in terms of the programmatic piece, but the data piece, I think, is the larger question that I think would be interesting to sort of map that out. Because food insecurity really doesn't consider sort of that end of
Quality.
it. Yeah.
Thank you.
So that's sort of the presentation of
Yeah,
the
thank
information,
you.
the data, and I think as you can see, there's lots of both assets and progress, and also there's obviously challenges that persist. And I think without a doubt, there continues to be tremendous effort on the part of the commission, as well as other city departments that are working to sort of close some of these challenges, but also the CBOs in the community that are kind of taking these head on. So wanted to give you the presentation of the information, but also I don't know if there was any additional questions you may have
I have
at
a
this point.
few. I won't keep you here too long because I do want more time to pour over this, and we'll make sure my colleagues who all wanted to be here, but given the close proximity to our council meeting, I'm sure they're all somewhere eating. But we will make sure that they get the annual report, and I know some of them have been in their offices, watching from there. So I appreciate the presentation, appreciate your work. And just a couple of questions. So earlier today in the city council meeting, I had leadership here from Samaritans to talk about the good work that they do. And I know you do have suicides accounted for here, but on those challenges that are underreported. I mean, so ultimately everything comes back to research and data, and with things like sexual assault or suicide, these continue to be some of the most underreported crimes and mental health illnesses and things like that, I think because of stigma. So it's either we can't get the universe, or you don't have the researchers dedicated. So I just wanted to, I guess, just ask, and if you want to revisit the suicide part itself, because anecdotally I've heard that those numbers continue to increase. By firearm or non-firearm. I don't know if most of your suicide accounting is based on drug use, or how we are counting that.
So I can start if you'd like, Dan. So we actually, I'm glad that Samaritans was here because we actually did do some work with them in the last fiscal year. They partnered with the cabinet in terms of enhanced trainings that they offered, and working with BCYF and the commission.
Yes, they did talk about BCYF. Okay,
And
good.
it was great. And also Boston Public Schools.
Yeah.
Yes. And in terms of what you've just highlighted, it is actually something when we look at, there was just a recent convening that Northeastern University School of Law pulled together around what, are called the diseases of despair. So drug addiction, and then also suicide. And so we did engage a consultant to help us look into the data more closely around suicide, and have been reviewing that because nationally, at the state and the local levels, our suicide rates are actually lower than national
Okay,
levels.
that's good, very good to hear.
However, when you look a little bit deeper and stratify by race and ethnicity, we have some preliminary information that suggests that there is a disparity and an increasing trend among a certain age group and also racial groups. So that is actually something that was brought to our attention and that we're reviewing.
Okay.
I don't know if you want
All
to
right,
add
so
to that,
That's
Dan.
fine.
Okay, great.
It's on the radar.
All right, good. I'm sorry it has to be, but
Yeah.
I'm encouraged to hear that it is. Oftentimes I find that there are trends in advocacy as well, that are mirrored by where we see spikes and increases. And then when those numbers begin to dissipate, usually the advocacy around those issues dissipates as well. And that is certainly true for HIV and AIDS, which we speak about, with less frequency and intentionality as we once did. But meanwhile, because many folks are continue to engage in high-risk behavior, and those high-risk behaviors are not usually in a silo. So I was asking the question about suicide because it's my understanding that we're seeing an increase in suicide of men of color. And I also, just based on the calls that I get, and I don't know if you can substantiate this, that we're seeing an increase in drug usage, specifically of meth, crystal meth, with an overlay of LGBT, youth, and men of color. And consequently, an increase in HIV and AIDS infections, and those new infections, the lion's share of that being borne by young men of color. So I just wanted to know if that's something that you believe to be academically supported. Is it something you're hearing? Just wanted to make sure we're not, thank God for modern medicine, and there have been tons of advances, but I don't want us to lose sight of HIV and AIDS and the other issues that I just cited. So is this something that you're familiar with or seeing or hearing?
So let me pause and see, Dan, I can speak on program side, but on the data question in terms of crystal meth and connection to LGBTQ.
Yeah, and I don't mean to diminish the impact of crystal meth, and it's out there, but on a relative scale, the Boston indicators have always had very low numbers of the crystal meth. And that said, it's been a part of the LGBT community, across the country. It's been part of that.
So it exists, but you don't see it you're not aware of it in the epidemic numbers. So comparatively, it pales in comparison, but
in Boston,
exists.
In other parts of the country, that's not the case.
Okay.
But the kind of information you're giving is the kind of flag that we would then, take very seriously to look to see what's happening in the data moving forward, as we're getting more. The data we're presenting here is a few years old already. So, and just from experience around drug epidemiology, the trends can, change very quickly, and we can have, a problem. So it's very important to be aware.
On the program side, we actually do have, both at the city appropriation level and with our federal funds that we receive from HRSA, the Ryan White Care Act, we actually do a fair amount of education and outreach to vulnerable populations. And so this is certainly something that we can go back to them and check on the different performance indicators that they gather through the program, if they're seeing an increasing trend in terms of intersection of crystal meth and high-risk behavior among the clients that are being served through our different community-based organizations.
So let me ask that. So when you talk about CBOs, I think about an organization like Fenway Health, right? And so you're in so how does that work? How are you conferring with them? So do they call you, are they prompted to call you because you have a monthly or quarterly convening? Do they just send you an email and say, this is what we're sending? Do they produce their own report that they turn over to you? So how might an organization like Fenway Health Center or any other community-based organization, it could be a faith-based institution that just talks about what they're saying. How do they communicate that to you?
So a couple different ways. So because we provide on the Ryan White funding, that's $15 million that the city receives to serve Metro Boston and also New Hampshire. So it's a regional grant. So in that instance, and also in our education outreach grants, because we provide community-based organizations, so health centers and other nonprofit groups, funding, they're required to provide us back with routine reports, and we have program staff that actually meet with, talk with them routinely to look at the different indicators. The data that we receive varies by the type of funding that we distribute and the contracts that we have. So that's one way. The other way that I can share with you, because we're going out to re-procure our federal funds, they just held a series of meetings in Boston, community dialogues, in Boston and also outside of the city and in New Hampshire, to make sure that the funding and the RFP that we're going to develop it's going to actually target the most salient issues that community is seeing. So they're in the process. I'm not sure if they've wrapped up. I'm looking at Catherine.
So grassroots up instead of top down.
Yes, to help drive the information, give us back information so that we can develop a procurement that's meeting the needs that are being seen.
And is that in general, or you're saying specific to
This is
Ryan White and HIV and AIDS? So let me ask about, so with that 15 million, and I know Marty's very big on, the chief rather, on evaluative tools. And so I know there's a lot of work happening internally to get us to that point. But I am curious about funders and, how are we meeting these disparities and how are those folks being evaluated? It's $15 million and split between New Hampshire and Boston. How much of that is going to Boston? And has it resulted in fewer HIV and AIDS infections, a greater wraparound supports for those living with HIV and AIDS?
Whole host of things. So there's actually a very robust component around data collection that happens through JSI, actually, that is our partner, where there's evaluations that we're required to provide to the federal government. And then in terms of outcomes, that is actually something that we also track as well. And there's a whole new quality management council that's being stood up to look more closely at the data and how we're meeting different goals and objectives, and if we're making an improvement because of the investments. The majority of the funding actually is in Massachusetts, so it's driven by prevalence of HIV/AIDS. So the majority, and I can get you the breakout, but the majority is in Massachusetts, in Boston.
But Council, there's no question that the Ryan White funding has dramatically impacted and over years decreased the HIV rate, new infection rate, and then also the complexity of the disease within the community moving forward. I don't have the specific numbers, but there's no, and we can get them for you, there's no question that there's been an impact. But one thing I will say, and just to the piece that Dan said, because if our CBOs are watching, Boston-based providers who work with the LGBTQ community, I think will tell you anecdotally that they do continue to have a concern with the presence of crystal meth in targeted communities, men of color, targeted communities of folks who may engage in same-sex behavior but don't identify with the community, and that link back to different kinds of behaviors that then can bring some concern. So I think from AIDS Action to Fenway Health to Boston Glass to Bagley, you're going to see an emphasis that they've made in ensuring that we don't forget the HIV and AIDS epidemic, and that we don't, because the impact of the disease is different today, that we don't forget that prevention, primary prevention, is still a huge piece of that work, and that populations today may have forgot the struggle that came before. So I want to note that, because what we're seeing in the data may be one thing. CBOs are concerned. Many of them are doing public awareness campaigns and other initiatives to ensure that communities of color, especially within the LGBTQ community, get access to the care and treatment that they need. So the data may be in one place, but the on-the-ground CBOs may have another conversation they're having.
Thank you. We spoke about low birth weights and infant mortality. There was recently very encouraged by a national movement around the health of moms, which has led to a greater awareness around maternal mortality rates, which are growing because of post-birth hemorrhaging. We also see sharp disparities along race lines there. I think Black women are dying 3 to 4 times that of their white peers. So I was just wondering if this is anything that the Commission is seeing here, thinking about addressing the issue of maternal mortality, if we have any
we
data or
actually-
information about. It's a newer issue, so.
Yeah, it is, and we recently did analysis. I'm trying to recall it. I remember that for us to present the data, we need, we need to have a certain number of cases, and at least 5. And I think we put many years together and didn't have 5 cases.
Wow.
So
Okay.
we can go back and we'll double check this, but that's my recollection.
Okay. All right, great. And then, since we're talking so much about data, foundationally that's required in order for you to provide this comprehensive report, what do you need from us, from the city council, from the city? I mean, I know you consider us to be good partners, but, and you're in the midst of your own sort of, reorg and realigning and, coordination of services and the like. But since the data collection, the research is so important, what are the things that we could be doing as a council to better support you in that work? Is that staffing, dedicated researchers? I don't know how many we currently have.
All the above.
Seems very laborious. So, what do you guys need? Is it new technology? What do you need?
I can start,
Sure.
and Dan and Chief can jump in. So I'm actually really proud of what we've been able to do with the staff that we have. Obviously, given some of the analyses that you've seen and movement towards using data in a more and getting access to more timely data, there are some things that we've begun to do in partnership with the State Department of Public Health. In terms of timeliness. There's also the fact that not just
Excuse me, in terms of sharing of data?
Data sharing,
Because that was
yes.
an issue.
Yeah, it's
So
a challenge.
Okay.
But we're
And getting it
working
in
on it.
real time, right?
In a more timely way. So there's
Okay.
some data that, there's a data lag, and there's a whole process at the State, having worked at the State Department of Public Health, I know that there's a whole process in terms of closing, for example, different files like the death records. So we've been making some good progress with the state on that front. I think in terms of staff, obviously, any additional resources or investment in terms of building out the staff, because this is core public health. What we do is so centered on public health surveillance, and that surveillance helps drive what we're doing in our programs and that of our partners, community
So how many
organizations.
dedicated researchers do we have? And is that commensurate and on pace with what the investment has been in the past? Because I don't know if it changes based on population or
So
need.
presently,
demand.
our office is about 9 individuals of varying levels of expertise. So when we think research, we have folks who, perform research that rises to the level of peer-reviewed journals, manuscripts.
Okay.
So we have some individuals can do that. Others are working towards that. But we're all very capable of doing a lot of work around the surveillance and population health types of analyses. I think that from a support wish list, we could, ideally, with if we were to grow, we would be able to support, just reach further into trying to develop, further develop capacities across the commission and the bureaus, et cetera, and then working with partners outside of the commission as well. I don't feel that we're, that we're limited in terms of that. I think we've got a very strong office and a lot of support.
Oh, I agree.
So,
I can give
And
you
you
by-
all weren't complaining. I prompted you with the question.
Right. By way of comparison,
Yes.
just by way of comparison. So we probably have, Dan said 9 on his team. Across the commission, maybe close to 20 staff that would fall under like a a title of epidemiology research, right? By way of comparison, New York City Health Department, I think, has close to 300 people who they would define as research. This is actually something that we talk a lot about in our Big Cities Health Coalition. We're actually on the low end when you compare us to cities that we're more comparable to. So Seattle, King County, I think, has many more staff than we do in this space, but I think it's a good team, and we'll continue to, on the federal front and other grants, that's actually how we've been able to grow the staff, because we try to do as much as we can internally for programs that are able to secure those federal grant awards that have an evaluation component, keep as much as we can in-house to grow.
Well, that was my question, certainly since it seems, in Washington, there's, we have folks that don't believe in science or public education, or public health. So, we're having to absorb more of the financial investment to ensure that it will be sustainable. Because that's been my frustration with grants, is that they're often a one-time investment, and we're able to make great strides, and then the rug is sort of pulled out from under us. So if there were grant opportunities that were perhaps multi-year, or, it seems that all of those things are vulnerable right now under this current climate, so.
Councilor, the only thing I would say outside of this realm would be something that you're already doing that I think I would love for you and other councilors to continue to do, is help to raise the visibility. Because the visibility of what we learn and the facts that we're sharing.
Helps to drive the investment.
It helps to drive that, right?
Okay.
So doing the work is great, and having, all the research to do it is important, but if we're not telling that story and we're not lifting it up, and we're not ensuring that this health conversation is happening on a variety of topics in this chamber and beyond, then it's all for naught. So the pieces of giving the visibility I appreciate, but also I think the more that the council can do to help us raise it up would be much appreciated.
Okay, done. And then my last question, wanting to be respectful of folks' time, to the point of visibility, is do you find a direct correlation in your investment in public awareness and media campaigns and billboards, everything from smoking cessation to biking to healthier and fresher foods? Do you find that when you've made those investments, particularly in communities that have a concentration of poor health outcomes, that there is a correlation, that when you've made that investment in public awareness and in marketing, from bus shelters to billboards, that you do see an improved outcome? Is that something you can quantify?
I'd have to go back. I mean, the most recent initiative or project that I can think of that had a big investment in terms of a public-facing campaign was Let's Get Healthy Boston, which is Partners in Community Health was what the CDC program was, and that was a 3-year, multi-year program with a fairly large percentage of the funding going out to support efforts to address the built environment. And then there was also an effort, it was definitely focused on place-based investments and using actually some of our clients and constituents in the campaign, which was great. We can go back and see in terms of what they were tracking in terms of increased physical activity, access to more fruits and vegetables in the communities through farmers market. We can check and see if that actually did.
I'm just curious because, certainly we believe, and that's why we try to control what goes on billboards, particularly in communities that have disparities along all outcomes, that we are, trying to control that because we do believe it has contributed. So if we believe, alcohol advertising and things like that have contributed to poor outcomes, I'm hoping that by your promoting healthier behaviors, that it has contributed to improved outcomes. So it'd be interesting.
I think it was. And I think when I went with them to their end of grant celebration that they had, unlike some of the other grants where they wind down and people are really, really sad because the funding has ended, I was actually really impressed that one, I guess, byproduct or consequence was building communities to be better engaged and advocates. And at that end of the year, kind of the end of the cycle celebration, each of them were bringing in all of the proclamations that they had received from their different elected
That's true.
officials. And it was pretty exciting to see.
Well, they
that-
also like the swag. You had some great swag for that campaign.
We did
So
have
I have a
great
couple of those
swag.
T-shirts
You do?
myself, so I know. Well, this has been very informative, and, you know, one issue that I know you share a commitment to being a partner in, addressing, you know, as a city in a holistic sort of integrated approach is that of how do we combat trauma. We could just have a hearing just about that, so we will not get to unpack that today, but I know where to find you, and we'll continue to enlist you in that conversation, and we thank you for your partnership in that work. And as the founder and chair of the Committee on Healthy Women, Families, and Communities, you know, I just firmly believe that the health of community only happens if we're intentional about it in our advocacy, in our policymaking, in our investments, in our resources. And I just thank you for your partnership in intentionally building healthier and safer communities. And we look forward to being forward-facing with what we've learned here today.
Thank
So
you.
thank you for your time.
Council.
Thank you.
And thank you for your leadership on so many issues that we work on, and particularly prioritizing prevention and across all of the work that we do at the commission.
Thank you. It's a team effort here. And thank you to the entire team that's here, so, for what you do. All right, have a good one.
Thanks.
Thank you.
So you have no gap?